hypothermia and opioid-induced hyperalgesia. First, I'll start with therapeutic hypothermia. It's the controlled reduction of core body temperature to reduce the metabolic demand and to limit the ischemia-reperfusion injury following periods of reduced cerebral perfusion. Indications for therapeutic hypothermia are post-cardiac arrest care, particularly after VFib, neonatal hypoxic ischemic encephalopathy, traumatic brain injury, or spinal cord ischemia during aortic surgery. Mechanism of neuroprotection. Therapeutic hypothermia mitigates secondary brain injury via metabolic, reducing the cerebral metabolic rate of oxygen, that is 6 to 7% per 1 degree Celsius drop. Cellular, it decreases the excitotoxic neurotransmitter release, example glutamate, stabilizes the cell membranes, reduces the free radical formation and apoptosis. Hemodynamically, it reduces the intracranial pressure, blunts the systemic inflammatory cascades, improves the microcirculatory flow. Temperature target. Most modern guidelines use target of 32 to 36 degrees Celsius. Phases include, in induction phase, we rapidly cool to target temperature. In maintenance phase, we maintain it for 24 hours. Rewarming should be controlled, that is 0.25 to 0.5 degrees Celsius per hour to avoid rebound hyperkalemia and hypotension. Methods of cooling include external and internal. External cooling with cooling blankets or surface pads, ice pads, and evaporative cooling. Internal cooling includes endovascular cooling catheters and cold IV fluids only during induction. Physiological effects of therapeutic hypothermia include, in cardiovascular system, it causes bradycardia, increased systemic vascular resistance, and potential arrhythmias if the temperature goes less than 30 degrees Celsius. In respiratory system, it alters the gas solubility. It carries risk of ventilator-associated pneumonia. And electrolyte causes hypokalemia during cooling and rebound hyperkalemia during rewarming. Hematologically, coagulopathy is most common. Endocrine and metabolic, it causes hyperglycemia. And also during cooling, it increases shivering, which causes increased O2 demand. So we paralyze and sedate the patient to prevent shivering and excess metabolic demand. Complications include arrhythmias, electrolyte disturbance, infections, coagulopathy, hyperglycemia, overcooling or rapid rewarming, pressure injuries from cooling devices. Relative contraindications include active severe bleeding, severe infection or sepsis, and cryoglobulinemia. So my next topic. Sir, am I audible, sir?
Go ahead. Next topic. Continue.
Yes, sir. Next topic is hyperalgesia. It's increased pain response to a stimulus that is normally painful. In other words, the patient experiences pain which is disproportionately greater than that would be expected from that same painful stimulus under normal circumstances. Mechanism include sensitization of peripheral nociceptors. Tissue injury releases multiple mediators that lowers the activation threshold of nociceptors. Neurons fire more easily, which leads to increased pain from same stimulus. Inflammatory mediators. Tissue damage triggers the release of prostaglandin E2, bradykinins, histamines, serotonins that modify the nociceptor receptors and ion channels and causes peripheral sensitization. Upregulation of receptors and ion channels after injury. After injury, nociceptors show increased expression of TRPV1, which leads to increased sensitization of the receptors. Neurogenic inflammation. Activation of nociceptors cause release of neuropeptides from peripheral terminals. Example, substance P and CGRP. These produce vasodilatation, plasma extravasation, more inflammatory mediator release that creates a self-amplifying loop that heightens hyperalgesia. Following injury, there's sprouting of nociceptor fibers and that causes abnormal spontaneous activity that contributes to heightened pain. Peripheral contribution in opioid-induced hyperalgesia. Chronic or increased dose of opioids can increase nociceptor excitability via activation of peripheral NMDA receptors and also increasing the spinal dynorphin leading to peripheral inflammation, enhanced release of excitatory mediator. Opioid-induced hyperalgesia is a paradoxical phenomenon in which exposure to opioids results in increased sensitivity to painful stimuli. Because of activation of NMDA receptors, which increases the excitatory neurotransmitter and lowers the pain threshold. Increased spinal dynorphin that promotes increased release of excitatory neurotransmitter that amplifies the nociceptive signaling, which causes hyperalgesia. Persistent opioid exposure enhances the excitability of dorsal horn neurons, reduces the activation threshold, and increases the spontaneous neuronal firing. Peripheral sensitization. Opioids promote release of inflammatory mediators in peripheral tissues. Example, morphine 3-glucuronide act as excitatory compound and promote hyperalgesia. Clinical features: worsening pain and diffuse and localized, reduced pain threshold, lack of expected analgesic response. Drugs associated with opioid-induced hyperalgesia include remifentanil and morphine. Prevention can be done by reduction in the opioid exposure, usage of multimodal analgesia, NMDA antagonists like ketamine, avoid large boluses of opioids, and transition to non-opioid as possible. Thank you.
You finished?
Yes, sir.
Okay, very good. You are first year PG, isn't it?
Yes, sir.
Okay. Nicely prepared the answer. Can I ask you a few questions?
Yes, sir.
Okay. The question says therapeutic hypothermia. Is it the name?
I'm not aware of
You mentioned that in your answer itself. That's the clue I can give you. What is TTM?
the control.
TTM. T for Aravind, are you? Aravind, are you there? I see his name. I don't know whether he is there or not. Have you heard of the term targeted temperature management?
Yes, sir.
You mentioned that, targeted temperature. So what is called as therapeutic hypothermia has been renamed now as targeted temperature management.
Yes.
Okay.
Yes.
So you rightly said the indications, the mechanism of action, or how it helps. Okay. And how long you can give this targeted therapeutic management, or what is the duration you can keep a patient at a low temperature?
Up to 24 hours.
24 hours maximum. And which temperature should be lowered? Surface temperature or core temperature?
Core temp.
Core temperature. Yeah. So how do you measure the core temperature in this case?
We can use the temperature probe.
Temperature probe, which locations are ideal for measuring the core temperature? Which is the best site?
Esophageal.
Mid-esophageal temperature. Very good. Excellent. Why it is preferred as the best location for measuring the core temperature? which is the organ which is closest to the, when you insert the probe in the to the midpoint of esophagus, which is the organ which is anterior, anterior and closer to the esophagus. In the thoracic cavity,
Thoracic cavity. Heart.
heart, yes. So all the blood comes to the heart and gets pumped, isn't it?
Yes.
So you will get the correct temperature of the core tissues only at the heart level. Okay. So that is the reason why mid-esophageal measurement of the temperature is considered the ideal core temperature. What are the other locations where you can measure the core temperature apart from the mid-esophageal?
So rectum.
Can you measure through bladder temperature probe? Bladder, rectum.
Bladder, rectum, maxilla, skin, nasopharynx.
Can you measure it at the middle ear?
We can measure.
Can measure. Right. Now coming to the other next topic you said talk much about opioid-induced hyperalgesia. You said it's a paradoxical situation where a patient being treated with opioid complains of more pain. Isn't it? The pain is not reduced. On the contrary, he says pain has aggravated after taking opioid. So what are all the differential diagnoses for this condition? What other conditions can cause increased pain in spite of opioid therapy? Or what are all the other conditions which has to be ruled out before making a diagnosis of opioid-induced hyperalgesia? Supposing patient has become tolerant or patient has become addicted to opioids, can we complain of more pain?
Yes, sir. For we'll need
So
more.
tolerance and addiction are to be ruled out before you do that. Okay? So how to clinically diagnose opioid-induced hyperalgesia?
Sir, we can give opioid.
Reduce the opioid or give more opioid?
We can reduce the opioid and see, sir, if the patient experiences less pain, the pain is likely due to opioid. It's opioid-induced hyperalgesia.
Very good. So, do you have to give any other medications when you try to reduce the opioid dosage?
Sir, multimodal anesthesia can be preferred, like regional anesthesia.
Blocks?
And also blocks. And also NMDA antagonists can be given, sir, since NMDA receptors are.
So, what is the method of managing a patient who is addicted to opioids? If he complains of severe pain in the post-operative period, he is a known addict for morphine or pethidine or some narcotic drug, and he comes for a major surgery. He goes on pestering you that he is having excruciating pain in the post-operative period. What is the best method of managing that pain? Can NSAIDs or the regional blocks will be useful, or is there any other thing which has been suggested for?
Nicotine.
The drug that you suggested now, what is the drug?
Ketamine.
Ketamine. How will you administer that ketamine? If you want to treat a patient who is addicted to opioid drug, you want to reduce his post-operative pain. How do you, what is the dosage that you have to administer and in its form? Can you give it as a single bolus of intramuscular or intravenous, or do you have to use it as a?
Sir, in 1 minute, sir. Intramuscular.
Intramuscular?
Ketamine can be given, sir.
That will last only for about 15 minutes. Intramuscular ketamine has a very short duration of time. Whereas post-operative pain will be there for days also, isn't it? So if you give one single shot, will it be sufficient to take care of the pain? That will give relief only for 15 to 20 minutes. So if you want a prolonged effect, what do you have to do? You have to use any drug if you want a sustained effect as an infusion.
Infusion.
Okay? So you have to give a low dose ketamine infusion. That is the answer you have to take.
Yes.
Okay? What is the normal anesthetic dose of ketamine?
Intravenous 2 to 3 mg per kg. Intramuscular 3 to 5 mg per kg.
So maximum 10 mg also you can give. Okay? Intramuscular, but the intravenous 1 to 3 milligram per kg. You say low dose, how low you can give? It will not be in milligrams, it will be in micrograms. How many micrograms are there in 1 milligram of any drug?
Sir.
Supposing you say I take 1 milligram ketamine, how many
1000.
micrograms of ketamine are there?
100.
1000.
1000.
1 milligram is equal to 1000 micrograms. Okay. So you can give 10 to 30 micrograms per kilogram per hour as an infusion if you want to give low dose ketamine.
Yes.
10 microgram to 30 microgram per kg per hour. That is called the low dose ketamine infusion.
Yes.
Whereas for intravenous infusion for anesthetic use, you have to give 1 to 3 milligram per kg per hour.
Yes.
So these are all the things that you have to know. Otherwise, you have done a good job by preparing the answers. I'll just show my